Good evening, everyone, and welcome. I'm Tony Segreto, and once again, so pleased and honored to be your moderator for tonight's In the Know Town Hall. Now, before we get started, we want to thank all of you for joining us. For those of you who were impacted but still have power, we hope you fared well from Hurricane Ian. And for those friends of ours who wanted to be with us but did not do so well in terms of power and maybe some damage, we wish them nothing but the best, and we pray that they can get through this pretty well. But for those of you who are with us, thank you so much. You know, we're looking forward to another candid and informative discussion with some of the brightest and medical minds at UHealth on a topic of great importance. And tonight, we're discussing men's health, specifically reproductive and urological health. Now, I have to start by saying that tonight's town hall is important for a variety of reasons. First of all, let's be honest, we really don't often have open, honest, fair, frank conversations about men's reproductive and urologic health. It's a matter of great sensitivity. And as you know, without appropriate information, and there is so much information out there, and early interventions, genitourologic issues for men can lead to advanced stages of illness. So let's set the scene about the significance of tonight and what all of this means. Men are at risk for several genitourinary diseases, including what you've heard of. You know what we're talking about: prostate cancer, erectile dysfunction, and benign prostatic hyperplasia, BHP. And a number of statistics highlight the impact that these illnesses can have on the quality of life for men. Did you know that almost half of all men between the ages of 51 and 60 suffer from BPH, numbers that increase exponentially now with age? Men are almost twice as likely to develop kidney stones as women, and erectile dysfunction affects about 30 million men in this country alone. Now, working hard to put a dent in these statistics, and there's some staggering statistics I just gave you, is a team of outstanding physician scientists. Now, this team is advancing research and treatments that are making a world of difference for men. And tonight, trust me when I tell you this, I've said it before, but boy, it never holds more true than tonight. We have the best and the brightest of this team from UHealth and the Desai Sethi Urology Institute at the Miller School of Medicine to join us and weigh in on these topics. They're going to help us navigate the vast arena of men's health and share the latest innovations that are advancing research on every front in this field. So we would please join me now in welcoming this incredible panel. Dr. Kaba, who is going to be with us, just to show how real time we are doing this in, Dr. Cobb contacted us about 10 minutes ago to tell us that he's still in surgery, but he's going to join us as soon as he can. But let me tell you a little bit about him. Dr. Kaba is the Director of Men's Health and Professor of Urology in the Department of Urology at the Desai Sethi Urology Institute. Now, while Dr. Kaba covers a broad range of issues in men's health, his main research interests are in urological oncology. Also with us tonight is Dr. Sanaj Poonen. He is the PAPCOR Champions for Cancer Research Endowed Chair in Solid Tumor Research. He's also the chair of the genitourinary site disease group at Sylvester Comprehensive Cancer Center and associate professor in the Department of Urology at the Desai Sethi Urology Institute. Dr. Poonen's main area of focus is oncology, with a specific interest in prostate cancer. Then Dr. Thomas Masterson also joins us tonight, is assistant professor of urology at the Desai Sethi Urology Institute. His areas of specialty are erectile dysfunction, Peyronie's disease, and male infertility, along with low testosterone and vasectomy. Dr. Hamendra Shah is professor of urology at the Desai Sethi Urology Institute. His main area of interest is the endourological management of enlarged prostate and kidney stones. Now, an extraordinary fact about Dr. Shah, and Dr. Shah, we may have to ask you about this. He is actually in the Guinness Book of World Records. You know what for? For surgically removing the largest kidney stone on record. So we may have to weigh in on that, just as an aside. And certainly, last but not least, Dr. Mark McCann is the lead primary care physician of concierge and executive medicine at the UHealth Concierge Medicine in Palm Beach. He will help us tackle general questions about men's health. And we are truly lucky, as you can see, to access this wealth of knowledge and expertise tonight. I said it was like the Mount Rushmore for doctors in urology? Well, I think it clearly is. Now, before we get started, we're going to go over how all of you can participate in tonight's conversation. You're going to have the opportunities to submit your questions during this program. For those of you who haven't joined us, this is what you're going to need to do. For those of you who have joined us before, you know the drill. It's pretty simple. On the bottom of your screen, there's a Q&A feature. You can use that Q&A feature to send us your questions. We want to tell you that every question submitted will be done anonymously, and we really promise to get to as many as we can. We've had a number of questions sent in to us the last 10 days, so we promise we're going to get some of those as quickly as we can. In fact, we're going to get going now. We hope Dr. Kaba joins us soon, but we have our first question tonight, which is really kind of a lesson and a little bit of a tutorial. So we're going to see if we can get Dr. Shah to weigh in on this. Dr. Shah, we have two procedures that we're going to be talking about tonight, some of which we've heard of and some of which we haven't heard of. So can you tell us a little bit about TURP and HIFU? And if Dr. Shah, if you can't do that, if you would rather have Dr. Poonen do it, please let us know.
Yeah, so the TURP is a traditional procedure in people with enlarged prostate who are not responding to medical management or who have developed complications because of enlarged prostate, like retention of urine, repeated UTIs, repeated gross hematuria, damage to kidneys or swelling on the kidneys. In such cases, we definitely go in for surgical management, and TURP is supposed to be a gold standard surgical option to treat enlarged prostate. But TURP has its own limitations, and it is main limitation is size dependent. As the prostate size becomes bigger and bigger, the risk of complications in TURP increases significantly. So anyway, any patient above 80 to 100 gram prostate, usually both American and European guidelines recommend that we go for HOLAP or endoscopic enucleation of prostate rather than TURP, because it becomes more safer option for bigger prostates than TURP.
Dr. Shah, thank you. Dr. Kaba, you have joined us. First of all, welcome, sir. We're so happy you made it.
I'm sorry, I didn't put on my shirt and tie. I just got stuck in surgery.
I hope the surgery went well.
It did. Thank you.
Good. Thank God. Okay, maybe you want to add to what Dr. Shah said about what we were talking about.
So thank you very much, Tony. Tony, it's good to see you again. I think one of the really game-changing parts of urology recently has been the description of a variety of different procedures for the prostate, which are based on the size of the prostate. For smaller, and basically the people in urology that have developed these guidelines have put together all the papers and all the research, and so it turns out that there are three basic sizes of the prostates that we look at. We have the smaller prostates, moderate prostates, and large prostate. Now, before I even go on, I have to tell you, the voiding symptoms that men have don't, and it doesn't make sense, but it does. The size of the prostate doesn't correlate with symptoms. We have guys with enormous prostates who have no voiding symptoms whatsoever, and other guys with smaller prostates, they're still a little bit enlarged, that have a lot of symptoms. So let's put that in the back burner for the time being. The size doesn't correlate with symptoms, but the size does impact what are the safest options for surgical management. Now, most people, when they have enlargement of the prostate and have voiding symptoms associated with that, they'll go on some type of medical therapy, and those include alpha blockers such as Flomax, alfuzosin, Rapaflo. Those are the big three that we deal with right now. But a lot of men don't like those medications because they cause side effects. A lot of men don't have an effective response to their lower urinary symptoms because the medications are simply not effective enough. So those are the men that go on to surgical management, in addition to the ones that Dr. Shah had mentioned, those men with recurrent urinary tract infections, blood in the urine, things like that. At that point, we kind of have the urologist then is responsible for meeting with the patient and going over all the treatment options. And we basically subdivide the patients based upon the size of the prostate. Smaller prostates, you can have a TURP, you can have a HOLEP, you can have a laser prostate surgery, you can have some of the minimally invasive approaches like Rezum, which is a steam treatment. We have another treatment that staples the prostate open called UroLift. And so those men with smaller prostates who have moderate or severe urinary symptoms can have a whole variety of different options. For guys with medium prostates, they have also a variety of different options, but those with the larger prostates have a tougher time because a lot of the smaller procedures that we do, minimally invasive, don't always work for those. TURP doesn't always work for an enormous prostate. So that's why Dr. Shah mentioned HoLEP, which is a laser procedure that he's one of the few people in the world that are really expert in this. And it's a wonderful procedure for the guys who have larger prostates, who previously, years ago, we would have subjected them to open surgery. But now we don't have to do that necessarily. And the HoLEP is really a nice option for us.
Dr. Kava, thank you so much. And I'm glad we were able to weigh in on this. Now, the first question that was submitted a couple of weeks ago, Dr. McCon, we're going to bring you in. Welcome, sir. It was so great to see you. And the question goes like this. Most annual physical exams no longer include a prostate exam. Should we insist on it?
Well, most of the patients that I see, I like to know what their prostate is doing. So I'm a little reluctant to just ignore it. And I think one of the reasons is the prostate got instrumented too often or biopsied too often if we had a PSA that was elevated. PSA is a protein that's also made by normal prostate tissue. So you can have a high number and not necessarily have cancer. But I'm a little uncomfortable with my guys walking around without ever checking it. And that was in the past what was recommended because it turned out that too many men got biopsied and had side effects from that. But we are missing some of the prostate cancers if we do that. So if I'm the patient, I would volunteer to have it done. So as far as insisting, I've had my own issues with my prostate, so I'm a fan of it. So I would recommend it to the patients and leave it to them, especially if their family history is strong and they have urinary symptoms.
Thank you. Thank you, Dr. McCon. Dr. Masterson, we just had this sent in. Is free testosterone as important as the total testosterone number?
Hey, thank you. So yeah, it's a great question. When it comes to testosterone replacement, we usually use total testosterone. Most of the guidelines are written to look using total testosterone as the cutoff. Usually 300 is what most of us will use. In instances where men are borderline, that's when free testosterone comes into play. So for those who don't know, free testosterone is what is unbound, and that's really what the cells of your body are actually seeing. So my personal practice is free testosterone. I usually check it in the guys who are symptomatic, who have testosterone levels, above 300, under 350, to determine whether or not testosterone replacement is indicated.
Dr. Masterson, I'm just going to throw this in, and I asked you this pre-show. There's so many supplements out there claiming that they can boost your testosterone over the counter. Are any of them worth it?
So I would say as far as boosting your testosterone, probably not. So the only things we know that really increase testosterone are either taking testosterone, or there are medications that will trick your brain into thinking your testosterone is lower, which then causes you to produce more of your own. If these things were truly effective, they wouldn't be supplements, they would be drugs. If you want to increase your testosterone naturally, the secret to this is diet, exercise, stress reduction, better sleep. There's no real secret to it, but you're better off with those than trying over-the-counter supplements.
Thank you for clearing that up, Dr. Masterson. Thank you. Dr. Poonen, welcome. We're happy you're with us. If MRI of prostate shows no lesions, is biopsy recommended?
Thanks, Tony. So I think you allude to the fact that MRI is being used a lot more nowadays in patients that are undergoing prostate cancer evaluation. And I think, Dr. McCon hit it on the spot when he said that the problem with PSA is not cancer specific. So it leads to a lot of unnecessary testing. And that unnecessary testing is actually a biopsy, which is a pretty invasive test. So MRI has helped to reduce the number of biopsies we do, because if you see something, that person needs the biopsy. The question is what happens when you don't? So the decision to biopsy someone really comes down to what their risk of cancer is. And the MRI helps you determine that. If it's negative, your risk is lower. So you have a less likelihood of needing biopsy than someone who's positive on the MRI. But the problem is the MRI is not perfect. When it's reported as negative, I would say anywhere from 20 to 30% of people, depending on where you're getting the MRI, may actually have something that the MRI just didn't pick up. So in my practice, if there's other factors, the PSA is significantly elevated, there's a strong family history, or you're seeing that PSA has been climbing, or other markers are suggesting there's a risk, then I do the biopsy even if the MRI is negative. But in many men, that's a good sign that they may not need anything further.
Great. Thank you so much.
From
Dr. Shah, this was just sent in to us. What is your opinion about the green light laser procedure?
Green light laser is a very good procedure, typically for moderately enlarged prostate. The same laser can be used either to vaporize prostate, which means just burn and the tissue disappears, or it can also be used to enucleate the prostate in the same way as we do with the holmium laser. And any of these lasers are all safer options for people who are on anticoagulants or blood thinners, because it is associated with less risk of bleeding and need of blood transfusions as compared to a traditional TURP procedure.
Thank you, Dr. Shah. Dr. Masterson, this was just sent in. We are getting questions just pouring in. If someone has both Catacil and ED, and the ED does not respond to typical medications, might the ED be caused by the Catacil? If so, what options are available to address the inability to get an erection?
Yeah, fantastic question. So I'll answer this by first saying, what do you need functioning for a natural erection? So there's 5 things. You need blood flow, functioning nerves, appropriate levels of hormones, relaxation, and stimulation. So any disease or any medication that affects any of those 5 things can affect your erectile function. So if you have a disease that causes a vascular insufficiency, which in Catacil it does, yes, it could be related to the blood flow. This is also a neurovascular disease. So if there's damage to the brain or any of the nerves that actually feed to the pelvis, then that could also affect it. So treatment options include pills, injections, vacuum erection devices, constrictive bands, intraurethral suppositories, injections into the penis, and lastly, a penile prosthesis. So depending on, again, the disease process, some of these treatments are more effective than others. So for this particular patient, I would have to evaluate you, see exactly what's going on, what you've tried, how you've responded, before I could make a definitive treatment recommendation.
Great, Dr. Masterson, thank you. Dr. Kawa, I just asked Dr. Masterson about over-the-counter for testosterone. So this question was sent to us: are any over-the-counter BPH products worth recommending to patients?
That's a highly controversial area. Most of the over-the-counter supplements have not been studied with the same degree of scientific methodology as the current prescription drugs have been. I rarely will tell a patient that they shouldn't try something. Most of the over-the-counter supplements are safe, but whether they're effective, I usually, there's some agents such as saw palmetto, Hygienium africanum, that have been subject to a little bit more rigorous study, but again, the studies have not been as good as the prescription drugs. So the saw palmetto and the Hygienium are some of the agents that I might say that are acceptable to try. Often, currently, the American Urologic Association has studied this extensively, and they don't really have a good statement at this point whether you should or you shouldn't try these agents, but they don't generally recommend them as a treatment alternative at this point.
So what is the answer to BPH? What is the best treatment then?
It depends upon the degree of symptomatology and the bother to the individual. I have patients, men are funny because they're very resilient. We go to work often. We try to provide. There are a whole variety of different, things that are supposedly under the male rubric. And we try not to let our health get in our way, which is to a disadvantage. Men don't take their health issues as seriously as women have done. And so what we find is that we're willing to put up with a degree of bother without having to go to the next step. So for some men, waking up once or twice at night is not too bothersome, but other men who find the sleep disruption terrible would be apt to try a prescription drug if it's really interfering with their ability to function during the daytime. So there's a lot of variability to this. One of the statements that the AUA supports is that BPH is rarely life-threatening, but the bother associated with the BPH symptoms can be significant. And so the things that we do recommend for people with BPH who are bothered enough are the prescription drugs and then the surgical procedures, whether they're minimally invasive or maximally invasive.
Great, Dr. Kava, thank you so much. Dr. McCann, how can I reduce the number of times I get up in the middle of the night to urinate? It's just sort of based off of what we heard from Dr. Kava.
Right. So, I think if we get away with only having to get up once and go to the bathroom before we go to bed, and empty our bladder as completely as we can, then we're not too bothered. But it all depends on how much liquids you've drunk. And we generally try to get people to drink enough liquids. So that's counterintuitive. As a doctor, I want them to have their fluids. So we're back to medications. And if we can find a medication that seems to work, like the Flomax or the Rapaflow, then we usually recommend that if they can tolerate it. Rarely does Sal Palmetto or any of those work when you get to that stage. It's just too far gone. So, and then if that doesn't work at all, then they're taking a trip to our friendly urologist to find out what's available beyond the medication. So I've got plenty of patients who don't mind getting up once, sometimes twice at night, and they live with that for 10, 20 years. And until it gets to the point where it's 3 or 4 times and they can't get any sleep, do they actually seek help like Dr. Kava recommended? He said they tend to be too tough for too long.
Yeah. Yeah, tough is the red badge of courage for sure. But I know I have a number of friends who are really big drinkers of water or fluids during the day, and if they don't cut themselves off by a certain time, they're up maybe 4 times a night because they've had so much to drink.
And we tend to make more fluids when we lay down, because all the fluids that's below the waist now is making its way back to the heart and goes to the kidneys. And so we generally produce more urine laying down than we do standing up.
Great piece of advice. Thank you.
Tony, so there's something that I just want to add to that too, if
Sure.
you don't mind, because I find that a lot of men also have either coffee or alcoholic beverages during the evening. And so that may actually contribute a little bit to waking up at night. The caffeinated beverages do cause you to want to urinate a little bit more often. So that's something. And the other one thing that I would would be important to mention is that some people with sleep apnea actually wake up several times at night, and sleep apnea causes an increase in urine production during the course of the evening. That's why it's important. Waking up at night is not something to be taken lightly, and it should be, we should be discussing these with our patients, these issues.
Very good, Dr. Kava. Thank you, Dr. McCann. Excellent. Dr. Poonen, another one, and I hate to be redundant here, ladies and gentlemen watching, but I think it's important that you know that these are real-time questions that are being answered, that are being sent in. So is there any correlation between past multiple bladder stones and bladder cancer?
So if you have a lot of infection or inflammation in the bladder because of, let's say, a chronic bladder stone, then there is a type of bladder cancer, a squamous cell bladder cancer, which is known to be affiliated more with inflammation, that you can be at risk at. But again, that's rare.
Well, I'm going to keep you here, Dr. Poonen, because this was sent in earlier. My doctor said my PSA is increasing and he wants me to have a prostate biopsy. What are my options?
Right. It's a good question, Tony. We see a lot of that. And I think, again, to Mark's earlier point, is PSA is a good test to screen for prostate cancer because it tells you guys that may be at risk, but it's not the best test to tell you who needs a biopsy or not, because it's not cancer specific. And so it does lead to a lot of men who don't need a biopsy getting a biopsy. And so what we've really found to be the best sources, instead of just going right to a biopsy from a PSA, is you have some other test. We talked about MRI early. That's probably one of the biggest players in that space. A lot of men will go for an MRI, and that will tell them whether they need a biopsy. There are other biomarkers. There's 4K score, exosome, other kind of urine or blood tests that are non-invasive that can also be used. But in some men, you will need a biopsy. And the biggest risk with a biopsy is infection. But I think there's a real trend now to the approach that we use. In the past, we would put an ultrasound probe in the rectum because the rectum's right behind the prostate. So it's the easiest point to sample the prostate, which is why the doctors used to do the digital rectal examination. And we would pass that needle through the rectum. And that's where the infection risk would come from, because you're taking bacteria from the colon and bringing it into the urinary tract where it's not supposed to be. But now we have more of an approach where we actually pass the needle through the skin above the rectum. So the needle is not actually going through the rectum anymore. And that has a drastic reduction in the risk of infection, to the point where we don't even need to give men antibiotics preoperatively ahead of time. So I think that has been a good thing for antibiotic stewardship. It's reduced the major side effects from a biopsy to the point where I don't think it's the worst thing in the world. But we have a lot of tests, even before getting there, to help us decide who needs one and who doesn't.
Absolutely fascinating. Go ahead. Yes, please.
As unpleasant as the digital rectal exam is, it done properly can sometimes discover a little kernel or a nodule or something that's abnormal, something that would make me want the urologist to take another look. So the knowledgeable finger is a very important tool.
Well put, I guess. Thank you, Doctor. Dr. Shah, after prostate treatment with radiation, can previously prescribed Flomax be discontinued if advised? And what would determine a decrease?
So radiation is basically treatment for prostate cancer, but radiation is also supposed to shrink the prostate to some extent as the cancer cells die and the tissue shrinks. But most of the patients do need to continue medications for at least a year or so after radiation therapy. And usually if they do well and if they're able to peak comfortably, then they can slowly wean off the medications and just keep under watchful waiting. So typically patients with a smaller prostate are more likely to be able to wean off medications than the one with big prostates, which may require to continue medications for their entire life, because radiation will only treat a cancer. It won't treat a BPH part, which is responsible for urinary symptoms.
Thank you, Dr. Shah. Dr. Masterson, this was just sent in as well. Does finasteride 5 milligrams as maintenance medicine for a prolonged time cause man boobs? If so, why is it still prescribed instead of other alternates which do not? Again, the 5 milligram as maintenance medicine for a prolonged time cause man boobs. So the question goes,
Sure.
So why is it still prescribed instead of alternates which do not?
Yeah, so what we're talking about is the man boobs are gynecomastia, so it's breast tissue development in men. Finasteride works by preventing the conversion of testosterone to its more potent dihydrotestosterone. And one of the side effects of this is that your estrogen can actually increase, and that can actually lead to breast tissue development. Why is this medication still used? Well, it's really the only medication in that class that actually shrinks the prostate. And it's used because it's so effective in doing it. The other medications, the Flomax, the alpha blockers that we were discussing earlier, they work on the musculature of the prostate to make it relax, but they don't actually shrink it. So the kind of short answer is it's a side effect that can happen with finasteride. It doesn't happen to everybody. If you're developing that side effect, you may be a patient who shouldn't be on that medication anymore, maybe a surgical candidate, but should explore other options.
Great. Thank you very much, Dr. Masterson. Dr. Poonen, so this was just sent in to us. Please discuss the prostate cancer treatment HIFU, HIFU. What are the indications and contraindications in this? Does the procedure minimize urinary incontinence and ED? And how effective is it in eradicating cancer?
Yeah, great question. So HIFU stands for high intensity focused ultrasound. And it's one of the various ways in which you can deliver an energy source to a part of the prostate to ablate tissue and kind of kill off cancer cells in that area of the prostate. So it's part of a spectrum of therapies called focal therapy. So as we know, some men have cancers that don't need to be treated and can be watched. Others have ones that are more aggressive and need surgery or radiation, which comes with a lot of side effects. And many men will ask themselves, if my cancer is just in one area, can't I just treat that one area? And that is what things like HIFU does. It treats just that area. And because of that, it does come with less side effects from urinary problems, from erection problems. But as you can imagine, you're not treating the whole prostate. You're only treating part of the prostate. So the risk of a cancer coming in an area that was not treated before, or risk of incurrence in general, is higher when you compare it to, let's say, radiation or surgery, because you're treating the whole prostate in those cases.
Excellent. Thank you so much. Dr. Kaba, how is BPH associated with ED?
So there are differing opinions on this. Both ED, or erectile dysfunction, and BPH occur in an aging population of men. You rarely see, so BPH basically starts at when we're in our 30s, and we don't really see the symptoms until we're in our 50s or late 40s. Erectile dysfunction also occurs in an aging population of men. We rarely see men under 40 have erectile dysfunction related to an organic or physiologic problem. So we have two disease entities that are occurring in aging men. So that's one component of this. The other thing is, though, that there is another component of erectile dysfunction that occurs probably as a result of the enlarging prostate. We haven't really done a good job of explaining how that happens, but most of the epidemiology studies have shown that erectile dysfunction occurs more often in men with larger prostates. Whether or not the enlargement of the prostate interferes with nerve transmission, that's been speculated. The blood flow to the prostate may be stealing some of the blood flow to the penis. It's hard to say exactly what causes it. Nobody's really come up with that key component of it. And whether this is an association or a causation is still not yet determined.
Dr. Kava, thank you. Dr. McCann, I'm going to bring you in on this because one of the questions sent in, and this is the obvious one to come to you right now, is what are the causes of erectile dysfunction? So that there appears to be a lot of, I guess, debate over what really the causes are. I guess there could be multiple causes, correct?
Yeah, well, I mean, besides trauma, which is something that could injure the perineum, that area between the rectum and the scrotum, like bicycle riding or rodeo riding, could damage the nerves there, is one possibility. The other more common possibilities are diabetes, which affects both blood flow and nerve health, is probably much more common in the population. Hypertension and vascular disease also steals blood from the penis and can affect that performance as well. So trauma, diabetes, and vascular disease are the most common causes.
Excellent. Dr. McCann, thank you so much. Dr. Poonen.
Tony, just to add to that,
Yes,
too,
please,
because,
Dr. Kava.
it's important that men with erectile dysfunction, it turns out that many men don't go to doctors, as you know, and they wait until their 50s, 60s to go see the doctor finally, after a prolonged period where they haven't gone back. Men often equate health with fitness, which is a problem. It doesn't always correlate. It turns out, so that Dr. McCown is very important to us as urologists, as our primary care doctors. Many men with erectile dysfunction present to us as the first time going to a doctor in years, and they come to us with a complaint of erectile dysfunction. It's important to recognize that erectile dysfunction is occurring in your 50s and 60s as a result, likely of vascular insufficiency or blood flow disturbances. Those blood flow disturbances, it turns out, are not related only to the penis, but they also occur in the heart and the general vasculature. So men who have heart disease, men who have diabetes, men who have artery disease and carotid artery disease often have erectile dysfunction, and vice versa. Men with erectile dysfunction have these too. So what we do as urologists often is we'll work in conjunction with our primary care associates to try to figure out, hey, this gentleman is coming to us with an erection problem. We can work on that, but we need your help, primary care doctors, in trying to figure out, is there an underlying problem here that can cause a heart attack, can cause a stroke, that can cause another problem in the next couple of years? And studies have really confirmed that this is the case.
How much does emotional play into it?
Well, every person with erection problems does have some emotional component to it. And that's part of what we do as urologists, is try to figure out how much of this is emotional, how much is truly organic or physiologic. And so we do a variety of tests in some of these men. Dr. Masterson can talk about some of these because he does a lot of the penile Doppler studies that we do, where we look at the blood flow in the penis in men with erectile dysfunction. If we find that the blood flow is perfectly fine, very often we can attribute the erectile dysfunction to an emotional component. I'm not downplaying the emotional component because that's significant, but we would like to, the treatment options would be better. Somebody with a strong emotional component to their ED should see one of our psychologists.
Right. Dr. Masterson, do you want to button this up?
Yeah, I mean, I think we're just piggybacking on it, but, circling back to the 5 things, blood flow, nerves, hormones, relaxation, stimulation, with that in mind, the penis really is a barometer of overall health in a man. So, if there is a disturbance in any of those things, either from disease processes, medications, it will be affected in your erections. And that last part, the relaxation, stimulation, that's the sort of emotional component. Men are more fragile than they let themselves believe. But if you had a problem with your erection the last time you were trying to have intercourse, that is all you're thinking about the next time you try to have intercourse. And it sets you down this terrible path where you can't relax and get in the moment. The extreme version of this is if you're in a stressful situation being chased by a bear, it's not to your benefit to have an erection at that time. So if you're stressed out during sex, it's never going to happen for you.
Yeah. Well, Dr. Masterson, thank you. When I'm running through the mountains, I will keep that in mind as I get bear sightings. I will make sure how I run is important. Anyway, well, I knew this night was going to be different, so I just figured we would have a little fun here. So, Dr. Poonen, how reliable is the 4K test as a cancer predictor?
Yeah, so the 4K test is one of a number of other biomarkers that are available. This particular test is one that's done just on a routine blood sample, and it looks at measurement of certain proteins in the blood, like PSA, as well as some clinical information as well. And it's been validated in several prospective studies that have shown it predicts pretty well. We did a lot of the work as well at the University of Miami, and we use it quite a bit. I mean, no test is perfect, and we are finding that tests work synergistically and in combination. So I often use a marker like the 4K with MRI a lot in my practice to figure out who needs a biopsy and who doesn't. But I do find it to be a reliable test.
Great. Dr. Poonen, thank you. Dr. Kava, this just sent in. I understand there is some competition between surgery and interventional radiology, but what about PAE, as an alternative for symptom-related and large-size prostates? Also has the skill in the arena.
So we mentioned before that the size of the prostate often will help us to determine what is the best option for a particular patient when they need some type of surgical intervention. Smaller prostates generally respond to just about everything. Moderate prostates respond to a little bit fewer, but certainly the majority of treatment options. For those men with larger prostates, we have several options. One, again, doing a TURP on somebody with a very, very large prostate can sometimes jeopardize their health because it takes quite a long time to do the procedure, and there's some additional blood loss during the course of the procedure. So HoLEP is one option. Another option that we often will incorporate for men with very large prostates is open or robotic simple prostatectomy, where we actually don't use instruments to scrape out the prostate, but we actually enucleate or take out the middle portion of the prostate. So the simple prostatectomy the HoLEP, in some cases the TURP, and then we have prostatic artery embolization, which is the new kid on the block, basically. It is a procedure that was devised by our interventional radiology colleagues. It is a minimally invasive approach where they basically feed a small angiocatheter or an IV catheter into one of the arteries, usually the wrist now, and they can feed a wire and a very long catheter down into the arteries going into the prostate. And by way of doing that, they can feed some small microspheres or beads into the arteries, essentially plugging up the blood flow to the prostate. Any organ that's deprived of blood supply will shrink. It will damage the organ, and it will cause it to decrease its volume. And so that's what this prostatic artery embolization does. In all honesty, the person that really brought this to and really pretty much, I have to give him credit for being the premier guy in the United States, is right here at the University of Miami, Dr. Bhatia. And he studied in Brazil, studied how to do the procedure, and then he really developed it and developed a whole program on prostatic artery embolization here. We make fun because I kind of laughed at it when he told me about it, and he handed me a series of papers. I was in a busy clinic and I put it in my pocket. I think I still have it in my white coat that day. So he kind of convinced me to send him a couple of patients to try it with. And we sent him the sickest patients who couldn't tolerate any surgical intervention, really the older, sickest people that we had. And he did an amazing job. So, we started, inviting him to participate in some of the care of our patients. And really, he's done a great job. And in some cases, prostatic artery embolization is really a good technology that may help for many, many men, particularly those interested in preserving potency, preserving their ejaculation, but also with larger prostates.
Right, wonderful. Dr. Kava, thank you so much. Dr. Poonen, if you have a low-grade bladder cancer, what is the best form of treatment? What is your opinion of BCG treatment?
Great question. So if it's your first time having a low-grade bladder cancer and it was small and you don't have a lot of risk factors, and the thing to remember is these treatments don't treat the bladder cancer. I mean, the surgery where you resect it out of the bladder treats it. And then you're giving these therapies really mainly to reduce the risk of recurrence. So if the bladder cancer is low grade, its risk of recurrence is already less. And so if it's the first time, like I said, and it's a small tumor, often I don't give anything. If it's a recurrent or a large tumor, BCG tends to work better for high-grade disease compared to low, and so I often will use mitomycin, but particularly I use Gemzar just because it has less side effects. So that's what I use if I give it to a low grade. But if it's a first-timer, like I said, we don't do anything, we just watch.
Great, thank you so much. Dr. Shah, can a person self-diagnose an enlarged prostate by touch or maybe done by a partner?
I think it's very difficult to diagnose that because the person who puts a finger inside should know how the normal prostate feels like and what is the normal size of prostate. So and as we all know, enlargement of prostate or BPH is a part of aging. So I tell my patients it's like graying of hairs, like all of us men will have it one fine day. What is more important is whether it causes urinary symptoms which are more bothersome. So, we don't treat everybody, as Dr. Kava said earlier, who are enlarged prostate. We treat if they have bothersome urinary symptoms, which are attributable to enlarged prostate. Because there are many patients who may have urinary symptoms, which are not because of prostate, they might be because of something else. Like we discussed about causes of nocturia earlier, and those patients may not really require prostate treatment.
Great.
So I think the answer is no. The answer is no, honestly.
We're going to keep you here, Dr. Shah. Is prostate cancer familial? And if so, is there an age at which exams should be commenced?
Yeah, so a family history of cancer definitely increases a person at a higher risk of getting a cancer of prostate because there are some genes which are involved and they can increase the risk of cancer significantly. What we normally see is we see the age at which the person in the family, like father or grandfather or cousin or brother, was diagnosed with cancer. If somebody tells me that my father was diagnosed with cancer at the age of 85 or 90, and he lived with that. He didn't have any problem and he died because of stroke at 95. Then, that person will possibly just be continuing regular PSA screening after he becomes 50 years, as recommended by, guidelines of American and European Urology Association. But if the father was diagnosed with the cancer at the age of 55, and possibly had a metastatic disease at the age of 60, then that guy should start screening with a PSA at least 5 years before the father was diagnosed with a localized cancer. So, we may start screening that person with a PSA maybe at 40 or 45 if his father was diagnosed at 50 or 55 with an advanced cancer, So we not only take into the history of cancer in mind, we take the age at which they were diagnosed and how aggressive that cancer was to decide if that person has high chance of getting a cancer or not.
All right, great, Dr. Shaw. Now, Dr. Poonen, I know you know a lot about this as well, but I have an add-on to what we just asked Dr. Shaw. And the question was just sent to us. After prostate surgery, should my PSA test be 0?
Right. So we've heard two different types of prostate surgery. So a lot of the surgery we've heard from BPH is just removing the inner core of the prostate. And so while your PSA will go down drastically, it may not be 0, but that's not a cancer surgery. That's more of a BPH surgery. For cancer, when you're talking about surgery, you're talking about a radical prostatectomy, which can be done in various forms, but there you're removing the entire prostate. If the prostate is gone, there shouldn't be any PSA. So essentially, your PSA should be 0.
Very good. Thank you so much. Dr. Kaba, what medicine can I take to prevent or reduce urinating 3 or 4 times a night? I know we've talked about this a little bit. This person's been using oxybutynin, which does not work for me, he says. What are the pros and cons of the different methods to urinary retention in the bladder?
So a variety of medications are used for the prostate to improve the flow. And for somebody who's retaining a lot of urine, often they'll have some frequency and urgency as well. When we look at the symptoms associated with prostate enlargement, we kind of subdivide them. We used to call them obstructive symptoms and storage symptoms. Now we refer to them as voiding and storage symptoms. The voiding symptoms are the flow, needing to push or strain to get the urine to come out, feeling that you're not quite emptying the bladder every time. Those are the voiding symptoms. And then there's a whole group of symptoms related to storing the urine, the frequency, urgency, waking up at night, and sometimes, in fact, urgent continence. So the obstruction from the prostate causes a variety of changes in the bladder, which can lead to some of those storage symptoms. And we have medications that can address them. Things like oxybutynin and sulfenicin. Enablex is another one, which is darfenicin. These are all of a class of drugs called antimuscarinic drugs. And what they do is they relax the bladder so that the bladder doesn't give us that signal that we have to go so often. But the same token, what they do is they interfere with the bladder's ability to empty. They don't allow the bladder muscle to contract as strongly as it did before. So there's a side effect of these drugs, not to mention the fact that they can often cause dry mouth and constipation. There's a new class of drugs called beta-3 antagonists. And what they are, there are 2 of them, mirabegron, and the other one, I'm blanking the brand name is Gemtesa. And these are new agents that just came out that don't relax the bladder as much, but they also reduce some of the symptoms, that urgency that many men have. So I would encourage anybody who has a lot of these urgency type of symptoms or storage symptoms to really consult with a urologist. These are some of the more challenging ones to treat, but they also may be a signal for something else that may be going on. It may not be that the bladder is overacting because of the prostate, but in some cases we've seen some people with bladder tumors have some of these urgency type of symptoms. We have seen people with kidney stones and the ureteral stones have some of the urgency type of symptoms, and it may also be reflective of something else going on. So I would encourage anybody with storage symptoms, definitely see the urologist.
Great. Dr. Kaba, thank you. Dr. Masterson, can inguinal surgery contribute or cause ED?
Yeah, so inguinal surgeries that can cover many things, but I'm assuming we're talking hernia repairs, possibly varicocele repairs. And really the blood vessels that go through there don't actually go to the penis. The ones that feed the penis are much deeper into the pelvis. So inguinal surgery should not in and of itself cause erectile dysfunction. Though I say that with a lot of caution because many surgeries can be done through that area.
Thank you, Dr. Masterson. Dr. Shah, what exactly is the SOLAP procedure?
Yeah, the SOLAP procedure is a short form used for saltive laser enucleation of prostate, So typically, if the prostate is like orange fruit, in enucleation, what we do is we remove the entire pulp of orange in one piece, and then use a separate instrument, which is like a grinder in the bladder to break this prostate into small pieces, which are, suctioned out through the urethra. So depending on what laser you use, there are short forms which are used. HOLEP is mainly when you use holmium laser. There is a newer version of holmium laser called Moses laser, and somebody wants to label it or name it like MOLAP. So if you use a thulium fiber laser, which is another type of laser, the company's name is Saltive Laser. So they can call it as TUFLEF or SOLAP. So depending on what laser you use, that is the way acronym is being framed by the users or authors of the articles.
Very interesting. Dr. Poonen, you're shaking your head.
All of this has been very interesting.
Yeah, we have a question for you that was just sent in. Why do the PSA keep fluctuating in numbers?
So PSA, you have to remember, is prostate specific, not cancer specific. So, we do see men that have got bad prostate cancers and their PSAs tend to just go like this because the cancer is making the PSA and as it gets worse, it's going to make more. But for men with BPH and may not have a cancer, there's a lot of things going on in the prostate. You have a little bit of growth of the prostate every year. You have inflammation in the prostate. So typically these men will have PSAs that do this. And that tends to be okay. I have a lot of patients whose PSA will go up a little while and when you check it, it comes back. And I think that is why we have to be careful about using PSA as a reflex to just biopsy guys, because almost all men with BPH will do this. And where you catch them in that cycle will determine what happens if you're only using the PSA. So that's why we don't just use the PSA anymore most times to decide on biopsy.
Great. That's a wise, sage wisdom. Yes, Dr. McCon.
And then sometimes it's from activity. Let's say somebody comes in the office, you get the blood test, it comes back double, and you find out that they had intercourse the night before. So that can sometimes raise the level, maybe not double, but it can raise it. Or they have an infection and we have to feel the gland. And if it's very tender, then we usually treat it with antibiotics and then check it again in a couple of weeks. And prostates are difficult to treat. They have a sort of a special capsule around it that antibiotics have trouble piercing. So the antibiotics have to be used for extra long periods of time to make sure we get the infection cleared up.
Thank you, Dr. McCon. Dr. Masterson, this was just sent in. Why do some men have prostate problems and others don't? Could it be due to excessive sexual activities and/or masturbation?
So the first part of that question is why do some men have problems and men don't? I don't think anyone's going to be able to clearly answer that. That has to do with the physiology, just avoiding. You have the prostate and the bladder, the two work together. If you have, as Dr. Cava was saying, obstructive or storage symptoms, those are what you'll be experiencing. But does excessive masturbation or excessive sexual intercourse lead to voiding problems? There's not. That said, if you have certain sexual practices, you may be more prone to developing urinary tract and prostatitis infections, and those will certainly cause voiding dysfunction.
Thank you, Dr. Masterson. Dr. McCon, how does diet and lifestyle fit into urologic disorders?
Well, I think as mentioned before, those men who are more fit and don't have extra belly fat, generally their testosterone levels are reasonable and they don't have the complaints that other men do that tend to develop diabetes and hypertension. are often overweight centrally. We call it central obesity. So that tends to, as the central obesity goes up, the testosterones tend to go down. And that can affect their vitality and their strength and certainly their libido.
Thank you, Dr. McCann. Dr. Kaba, is there a relationship between lumbar spine issues such as compression fractures, stenosis, et cetera, and urological problems?
Yes, there is. For people with a lot of back problems, the bladder requires innervation from the lumbar spine. Most of the voiding reflexes that we have come from the L1 to L5 levels and the sacral areas. So if there's an injury to the lumbar spine or the sacral spine, this lumbosacral spine, those can impact the bladder's ability to contract. They also can, in some cases, also impact the erectile apparatus as well. A lot of the nerves from the lumbar spine go into the pelvic nerve plexus, and those are the ones that can get injured at the time of the radical prostatectomies and the radical cystoprostatectomies, because those are the nerves that can get injured. But if you have lumbar spine or lumbosacral spine issues, they can directly impact some of the erectile nerves as well.
Understood. Got it. Wow. What an hour this has been. Dr. Shaw, I gotta ask you before we go. How big was that kidney stone to be in the Guinness Book of World Records?
It was 13.5 centimeters.
Well, what is it, like a golf ball, like a little smaller than a golf ball?
No, much bigger. It's possibly like my entire palm. Size of my palm.
Gracious. No wonder you're in the Guinness Book of World Records. Listen, Dr. McCann, Dr. Masterson, Dr. Poonen, Dr. Shaw, Dr. Kava, you come running in from surgery. This hour just flew by. It is amazing. You were all so wonderful. Your expertise, your ability to translate all of this for all of our audience. They did not drop off the entire night. So we cannot thank you enough. It was just absolutely wonderful. And what was so beautiful about tonight was it was candid, it was informative, certainly eye-opening in a lot of cases, and once again proving to all of us how blessed are all of us, how fortunate are we to have these amazing, talented doctors right here in our own backyard. Well, regrettably, it's time to close this incredible town hall. We could probably go another hour for sure. Thank you all for participating in tonight's In the Know. Please remember that a full recording of this program will be posted online. Look for the link in coming days. You're also, in a moment, going to see a survey. It's really short. It's really simple. It won't take any time. It's important if you could please fill that out for us, because what that does, it helps us with this feedback, helps us understand your interest to improve our program. As always, I cannot thank you enough. We wish all of you and your family nothing but good health. And remember, as we say goodnight to you, it's always about the you. Good night, everyone.